So next up, we have James Maskell, who's a friend of mine. He is just a master connector. He loves bringing community together. One of his books, The Community Cure, which launched right as COVID came out, which is really tough timing. And another great book was The Evolution of Medicine, how to kind of go against the tide of the prevailing thought. And James is a thought leader, connector, an economist by training. But I think you'll have a lot to glean from James. So James, come on up.
All right, hard act to follow. My plan to do that, to follow, is to be 80% as passionate, 40% less politically incorrect, but I've got a British accent, so I think all of that come together. I think we're going to have a fun time together. All right, so I want to talk today about the community cure, and I had to change my slides a little bit earlier because ultimately between Michael's slides and the blue zones, I feel like there's a lot in common. And, I came to this, so the year is 2003. I'm in university in England, and I'm looking at the projections for the future healthcare costs of England and America. England, that by the way, has a single payer system, the NHS. America has this hodgepodge of whatever we have here. And the news isn't good. And I can see the projections for the future costs. And those projections are built on chronic disease. And at that moment, I realized, hang on a minute, this is going to go really badly and sideways, not when I'm in a nursing home, but like when I'm in my mid-40s and I have young children. And that time is actually now. Like you could project out and you could see that the costs of medicine became unsustainable in the year like 2025 to 2030. And that was in 2003. So after a sort of a shaking from the universe to say, hey, look, you should go and look into this because this is gonna be a thing in your life. I've spent the last 20 years trying to answer some pretty significant questions to see what could solve that. Someone said bending the curve of healthcare costs. How do we do that? How do we look at that? So the first question we have to ask is chronic disease reversible? Because people have chronic disease now, the implication or the way that people think about it is you don't have a chronic disease, then you have one, then you have a few, and then you die, right? That is the projected journey. That is what makes up. Like if that cost curve is going up like that, it's made up of millions of little cost curves where people are going on that trajectory. So then the question is chronic disease reversible? Now, this is from the journal Nature, most prestigious journal in science, called In Precision Medicine. And it showed when you look at the actual numbers, so this is the number needed to treat, right? If you look at the actual numbers, for what number of patients does the drug work for compared to what it doesn't work for? And these are the top 10 selling drugs in America. Look at this chart and tell me whether you think this is the plan. Because this is the plan, right? This is the standard of care right now. And for Crestor, if you're going to have a heart attack, for every one person it does work for, it doesn't work for 19. And that's the plan for heart disease. And by the way, this person here, their heart disease didn't get reversed, right? They're not now healthy. They're on Crestor forever. This is an uncomfortable conversation. And I know there's a lot of medical people here. But if we want to make a healthy Tennessee, this can't be the plan because the pharma-first approach for chronic disease has failed and is failing right now. This is one of those awkward silences that Joel talked about. They're great. I love it. Thank you. But yeah, look, this is it. Look at it. By the way, Humira over here for autoimmune disease costs $5,000 a month and only works for 1 in 4 people, right? So just think about where all this money's going. It's going here. And if it worked all the time, that'd be great. And I think many people during COVID, one of the things they became aware of was the difference between pharma marketing statistics like relative risk reduction, absolute risk reduction, and number needed to treat, which is the only really number that counts. Everything else is just marketing, right? So this is not the way. This is not even capable of reversing disease. Even if it worked every time, it's not reversing it. So I went on a journey to see where is chronic disease being reversed? Where do you have people where they start off well, they get unhealthy and then they go back to being healthy, like free of medication, because that's what bends the curve, clearly, obviously. Couldn't be more obvious. So over time, I moved to near Lake Lanier in Georgia, not that far from here, in 2005. And I started working for a clinic, and I saw chronic disease being reversed. So I saw people who came in, and not in 3 months, but sometimes normally between 6 and 9 months. I saw someone that came in the first time in a wheelchair that was now walking around. I saw someone who had got off all their medication. I saw people visibly transformed by doing many of the things that you've heard about talked in here today. And ultimately, that led me on a journey eventually to find functional medicine, because ultimately what I see is that we need a different operating system for medicine. We need an operating system that takes into account all of the different things that you've heard of today. And in that journey, this was like 2011, I saw this thing and I was like, you know what? What was really tricky about the early days of trying to find doctors that were reversing chronic illness is that they were all doing it differently, right? You had all the people that showed up at Joel's farm, the naturopathic doctors, the chiropractors, the functional medicine doctors, the Ayurvedic people, all of these systems of medicine that have been built over thousands and thousands of years with the goal of actually creating health. The problem is they didn't speak the same language, right? They're all speaking their own little language, means their own siloed, and it can't become a standard of care. To become a new standard of care, you'd have to have a universal language. And when I saw this, I was like, well, it's got a lot of the right things down here, modifiable lifestyle factors, right? Their relationships, their stress, their nutrition, their exercise and their movement and their stress, right? How are they doing? How are the patients doing on this? Over here, what are the triggers, right? When you start looking at patients' history, you see, wow, this person got type 2 diabetes 6 months after their divorce. That's interesting. Like, we should probably understand that if we can understand people specifically. And then these areas here are basically the key to understanding. One of the most frustrating things that happens for patients is in their mind, this is their health journey. Healthy, 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 healthy lupus. But clearly it didn't happen that way, right? Something was happening along the way. It's just that no one was picking it up, that it was happening, right? And no one was telling them, hey, this symptom that you're starting to have right now might be one of the core parts of the body breaking down to a point there where eventually you're going to be diagnosed with something. So this is why I thought, okay, this is a common language. And from that, I did a few things. I wrote a book, The Evolution of Medicine. I started a thing called the Functional Forum. And the Functional Forum is what got me connected with Dr. Mabry, and he started the East Tennessee Health Forum this time last year. And, you do a few little events in Johnson City, and suddenly you have the balls to put on an event called Healthy Tennessee, and that's Michael Mabry's story. Boom. But that's what it takes, right? Doing a little bit gives you the excitement to go on and do the next thing. And by the way, if you've never heard of functional medicine, or if this is news to you, we've got functional medicine royalty in the room right now. Dr. Patrick Hanaway, put your hand up, Patrick. You should give him a shout. Patrick Hanaway moved to Cleveland. You think you want to be part of a movement? You're really dedicated to the movement. Would you move to Cleveland for it? Patrick did, to kickstart the Cleveland Clinic Center for Functional Medicine. It was going to show you some of the research from here today. That's dedication to the cause. And Karen over there is the head of partnerships in the green. And functional medicine is working to try and, put this forward. So we're going to talk a little bit about why this is important. But we also need to put it in context. Because ultimately, I'm an economist and I'm looking for the most economically viable way to transform this state. And it can't be that everyone gets functional medicine because there's not enough doctors and it's too slow in its current form to be able to deliver it in that way. So then the next question, after I know that chronic disease can be reversed, right, is can it be reversed at the scale that it exists? This is the next most important question because it's great, wonderful if the richest 30% of Americans have a shot at reversing their chronic illness, but what about everyone else? Is there a structure by which we could do that? And that's what led to this book, This Community Cure. If you'd like to listen, if you like the smooth sounds of James Maskell and you'd like me to hear my own audiobook, you can download it for free, thecommunitycure.com/audiobook. But in that book, we're sort of talking about the work of this new medical paradigm, functional medicine. Some of it is lifestyle medicine in there, and it's sort of convergence with community. And ultimately, you heard a lot about that this morning, and I'm going to get into a little bit of that right now. This is a great quote. Shouting self-care at people who need community care is how we fail people. If the outcome of this event, Healthy Tennessee, is that you all go home and say, hey, you got to take care of yourself, you got to do this, you got to do that, it may not work. It probably won't work. And that's because if you are disempowered, if you don't have the ability to make a lot of new choices for yourself, you can't add a lot of new things, right? If you have three kids, 2 jobs, and no car, you can't go to the yoga class down the road. Right? We have to understand the ability to make change. And so this is, Nikita Valeria made this quote, and I think it's really critical when we think about how we're going to transform things. So look, health or disease is clearly biopsychosocial in nature. And I don't know if you saw earlier in the Blue Zones presentation, and Patrick shared this with me when I was chatting with him, out of those 9 things, 5 of them are psychosocial. Right? It's most of the thing that makes up either health or disease are psychosocial in nature. And yet most of medicine is focused on the biological, right? The medicine, metabolic, disorders, the comorbidities, it's all in the biological piece. But this psychosocial element is really where the rubber hits the road, and that's like driving so much of the dysfunction. And there's actually a lot of graphs, there's a lot of science showing that this is actually a bigger driver of all-cause mortality, physical inactivity, alcohol, smoking, food even, right? That loneliness, a lack of social connection is a bigger driver of mortality and cost than all of these different things. And look how much money that we choose to spend on these other things, how many public health dollars go into these other things, where actually the stress is the biggest deal. And this is why, I come to a conference and I'm about to give this talk, and Michael does his thing in the morning and the Blue Zones do their thing in the morning. I'm like, good, all right, sounds like we're all in agreement that this is what we need to do. But today, what my part of this is, yes, do those Blue Zone areas can transform the way that you make it easy for people to do healthy behaviors. But ultimately, what I want to do is sort of close the gap on creating new relationships, and how do we do that at scale in a reasonable way. So Michael showed this slide earlier. The crux of the book is that there's a thing called a group visit. And in this group visit, you can see the difference here, right? So on this side, if a lot of physicians in the room, this is maybe what your Wednesday afternoon looks like. You've got 8 different patients with pretty much similar types of things, diseases of disconnection, ultimately happening here, whether you want to call it diabetes or heart disease or mental illness or loneliness or whatever it's showing up with, but there's 8 cases of disconnection. Oh, it's funny even though I said it. There's 8 cases of disconnection, and they're all in their own little room waiting for the doctor to come in. Again, we're going to have another pregnant pause here. Because over here, what's happening? This is, let's say a health coach or someone who is leading the charge on connection and community. There was a conversation earlier, like Michael said, what about those people that went through a dramatic transformation in the group visit, right? This is them afterwards, right? They're not the doctor. They're not taking the bloods. They're not doing the, qualifying for a 99214, but they do have a lot of personal experience about getting healthy, and they can lead a conversation there now. Now, the evolution, this was an idea, this came out in 2013, was the first time I heard of it. There's many different people pioneering this area. But what you'll hear about a little bit later in the Cleveland Clinic is this is a group, but what you actually want is a cohort. And the difference between a cohort and a group is that a cohort is a group over time. Because yes, this is a much more efficient way of educating, right? But ultimately, the most efficient thing is for people to become friends in a group and support each other long-term to implement healthy behaviors for the rest of their life. That's the MOI that we spoke about earlier. That is the structure. People having friendships where those friendships support healthy behaviors. That's the whole game, ladies and gentlemen. We can leave after this. All we have to do is that. Will the Blue Zones predictably do that? I don't know. Maybe it will, maybe it won't. What does predictably do that? This does. doing cohorts, putting people who have similar life situations, similar conditions, putting them in cohorts, having them go through a curriculum, and working out ways for people to connect with each other. When we first started trying to do this, like as Michael said, the book came out January 1st, 2020, and my master plan at that moment. So the first book, The Evolution of Medicine, the goal was if I gave that to any doctor, would they read it and say, that's interesting. Maybe I should start my own functional medicine practice, leave my job, and start a practice serving the community, reversing chronic disease. The second book, the goal was if I gave it to a hospital administrator, would they say, maybe we should be doing group visits as a way of delivering this across the way. So I brought it out January 2020, very excited. And, March the 15th, suddenly this looks incredibly unlikely. And it's going to be unlikely for years to come, right? Because everyone's now shut away. And the whole book, the original name of the book was A Cure for Loneliness, because I recognized that loneliness was such a big driver, but I changed the name because I recognized that if you cured loneliness in this way, it wasn't only curing loneliness. It wasn't only giving people new friends and connections, but it was also providing the structure for people to actually do the healthy behaviors consistently. And you heard about some of that earlier with Michael. It could be in a church, right, in the Daniel Plan. It could be in an employer setting. Anytime you have an existing community, all you have to do is feed in a little bit of a healthy curriculum, and suddenly you have a powerhouse at creating community and creating health. And that's what we're really doing. It's like, how do we create health at scale? So this is the original concept. If the greater attention from your health professional can induce a larger placebo response, then what can the exquisite attention of 15 people do, right? Placebo maximized medicine. Why not? Well, the placebo is awesome. You do no medicine and people get better. You don't know why? Who cares? We should be maximizing the placebo effect. Being cared about by 15 people is valuable. Let's do that for everyone. And this is what happens when you're in a group, the exquisite attention of 15 people. How many times in your life do you get that? I get it quite a lot. I've got it right now. Thank you. You're all being very, I get great that, but most people don't get that. It's a transformative moment where people listen to them. It's really amazing. You should try it. Try it in your medicine. Is it transformative, Michael? Right? Okay. This is what happens when you do groups across a whole medical organization. This is there was a specific journal on group medicine that came out that all it had was groups. Okay. Does Tennessee want any of these things? Right, let's see on the thing. Do we want self-efficacy? Right? Do we want self-regulation of emotions? Are there any unregulated people in the state of Tennessee? Do we want mindfulness? Do we want engagement in life, self-monitoring, self-health directed behaviors? Just look at this and then compare it to the conversation we were having earlier about life in the mental health hospital for 7-year-old kids, right? Do we want any of these things? Of course we do. We want as much of it as possible, as quickly as possible right now. Interpersonal. Do we want empathy, social integration support, interpersonal learning, affiliation with clinician? Does that sound fun? Altruism. We need a lot of that too. This is the natural thing that happens when you put individuals into this group. At the organizational level, many of you are in the business of organizing medicine. Do we want efficient care, self-care, timely care, health service navigation, peer-to-peer delivery of value? Of course we do. We need as much of it as possible, as quickly as possible. This is Healthy Tennessee. Community, larger support network, community resource, resilience, and problem solving. What else? What are we doing? This is it. Just do this. Deploy group visits at scale across health systems. This is what we need to do. Personalized medicine is definitely for the future, but for people who are disempowered, it's a fairy tale. I'm going to talk to you about personalized medicine along the way, and the question we have to ask ourselves is, can you participate in it? We have to provide a baseline level of participation for everyone to be, to participate in their own health. And these are the structures that can facilitate that. When I was writing the book, The Community Cure, I went to Oakland, California, to a group there, which is in the business of executing groups, and it's called Open Source Wellness. And what I saw there is don't talk about it, be about it, right? It was a 2-hour group visit with 30 people. We played games, we ate together, we did mindfulness, the meditation, like it was actually happening. It's one thing to give a lecture to say, hey, you should do it. It's another thing to actually do it. And by the way, I got a vision for you for next year for Healthy Tennessee. This might be a bit outside of the box, but we'll see. So I went to the last conference I spoke at was the Mexican Association of Lifestyle Medicine in Mexico City in October. And I will tell you that the medicine was happening in the conference, right? What did we start off with at the beginning? Sitting is the new smoking. What have we been doing for the last 8 hours? Sitting in the chair doing that. Well, we're going to do that right now. Let's stand up. Come on. Stand up. We're going to take a little bit of it in there. And you can just shake it up a little bit. We're not going to do too much. I hate doing this. This is like embarrassing for an English guy. I'm not Mr. Motivate. I'm not personal trainer. But like I went to a conference and in between Patrick was there as well, right? Imagine, a little bit of stretching. We'll go side to side. A standing cat-cow is really good. Like you go like this and you feel it go that way and then, that way, side to side. You can do some squats, whatever. In Mexico, they had squats going. In between each speaker, they were in it. The food was amazing, whatever. And by the end of the day, everyone was doing a giant African dance. Now, I'm not going to say we're going to do that. We're going to aim for that for next year. Mexicans know how to move, but this was definitely possible. All right, you can stand up or you can sit down, whatever you want. But take care of yourself through the rest of the time. And I'm going to suggest, Michael, next year that be part of the curriculum because ultimately, this is not an intellectual endeavor, right? This is a participatory endeavor. The difference between the medicine that we're talking about and the medicine that we're doing is that it requires the locus of control to be on the patient. It's a movement from the doctor to the patient. And it couldn't be more different, right? And that's why it hasn't happened yet. When I wrote the book, The Evolution of Medicine, I was like, how will medicine adapt to chronic disease? And the reason why it hasn't is because there's a lot of friction, and we're going to talk about that friction as we go along here. All right, so then the last part is, can chronic disease be reversed in an economically viable way? And that's when I want to spend the last minutes here, because I know in this audience, there are doctors who work for systems. There are people that run health systems and big groups. And I've been waiting my whole career to speak to you, so I'm going to let it rip right now. Okay, the first thing we're going to do, you talk about friction, right? You talk about friction for a moment. Like, what is stopping this from happening? We've all kind of had this heart moment at the beginning of today where we're like, yes, of course, we all want to be healthy, we want to get people into healthy behaviors, all those kind of things. Is there a model that could showcase the way to an economically to a new way of doing health where we order care in the right way? And ladies and gentlemen, there is, and I found it on my way. I didn't invent it. It's called the naturopathic therapeutic order, and it was invented by naturopathic doctors. Now, the irony is, naturopathic medicine is illegal in the state of Tennessee, right? We're all here saying for the first time that this makes sense, it's this new idea, it's all here. Why wouldn't we listen to the people who have obviously been in tension with exactly the problem that we've been dealing with for 100 years? Naturopathic medicine is illegal in this state. And actually, we got a couple of naturopathic doctors here, only the healthiest looking people in the whole room. And give us what you've got here. Here is a bill. We're going to give it to the Health of Tennessee. This is a stunt, by the way. This is going to get weird. This is a bill to unban naturopathic doctors in the state of Tennessee. When I tell you what this is, if you don't agree with it, I don't think you're a human, right? I don't think you can think about this. This speaks to me as an economist, but it also speaks to me as a human, right? Let's start at the very bottom. The whole thesis of this model is that you start with the least costly, least invasive interventions and work your way up. I can understand why that is triggering to an emergency medicine doctor, because in emergency medicine, when there's an emergency, you need the best clinician to work out the plan right away. Chronic disease is only becoming an emergency because we're dealing with it in completely the opposite way that it needs to be dealt with. So what do? First, establish the foundation for optimal health. Identify and remove obstacles to cure. Assess the social determinants of health. Ooh, I've heard that one before, right? This is the foundation, and obviously is the foundation If people can't participate, they're not going to get healthy. Second, stimulate the self-healing mechanisms. Recognize the VIX Metacrix Nextri. I'm just saying with this, right? Stimulate the self-healing mechanisms. Can you see the crossover to Joel's work and what we just talked about, right? It's like you plant a cabbage and the cabbage grows, and you don't have to do that much. Just nature knows how to do it, right? You sleep well, you take care of yourself a little bit, the body knows how to heal. Like, we're a part of that, and we're using it to like 0% of its potential. So that could be sleep, it could be tapping yourself to get over stress, whatever. It costs almost nothing, right? And it's easy to do. Third, support and restore weakened systems. Basically the nutrition, right? Eat the right food. This is supporting the weakened systems. As I said earlier, it doesn't happen healthy lupus. There's this whole bit in the middle where people are getting sick, they're not eating the right food, it's not being picked up, the symptom cluster doesn't make sense, you're fine, it'll go away, it doesn't go away, and now they got lupus, right? That's the journey that everyone's going on. But if we started with this, we could get there ahead of time. Address physical alignment, there's chiropractors in the room, physical medicine. Now we have natural symptom control. This is, use of supplements basically. And then if and only if, right? IFF, if and only if all of this doesn't work to get rid of your chronic illness, which it obviously does most of the time, drugs and surgery last. Have you ever seen that South Park episode where they are talking about the food pyramid and they go, it's upside down? And they go, no, sir, that would put fat and oils at the top. And they do it. Blood sugar stabilizing. It's a bit of a joke. It's South Park, whatever, but it's not that far off. Surgery's at the top, last, not first, right? Drugs just below it, kind of last, not first. This is a complete reversal of the way that we're doing it. But first, do no harm. Pregnant pause. First, do no harm. That is the basis of the oath that we take. This is not harmful. And ultimately, this is my own version of it, where essentially you can do these bottom three layers in the same group, right? This is the most economically efficient, radically transformative thing that we could do in medicine. So I made my own one because I'm not really a pyramid guy. I'm more of a circle guy because I'm a community guy. So this is my model. And this is called the 5 C's. Joel had 5 P's. I got 5 C's. Ultimately, from an economist's point of view, I want to share how this works. So what it is that each color, if you're thinking about it, right, I know the physician groups who put this on are in value-based arrangements, right? So if you're in value-based arrangements, I want you to think about that each color gets progressively higher in a per member per month cost, right? So the ideal thing is that the culture is so awesome that you don't need anything else, right? And you could see an example of that would be maybe an actual blue zone, right? Go to Costa Rica, go to the Nicoya Peninsula, go to a blue zone and experience it. The culture reinforces health so well that you actually don't need the epic hospital, right? You don't need those kind of things to reduce, to keep healthy because the culture does it. Now, we're a long way off in that culture. What we talked about this morning is that there's lots of different ways that culture is reinforcing the most unhealthy things, right? Tailgating, as an example. I know you guys love tailgating, but that is, community created around the most unhealthy thing possible, which is drinking 17 beers and eating whatever you eat at a tailgate, right? So this is the culture. Now I want to talk about a few things. The most obvious thing to me, and Joel mentioned it earlier, teaching, actually growing a garden, right? Again, like if you want to teach the next generation of Tennesseans about the difference between to come to an abundance mindset, start by putting a little seed in the ground and watering it and seeing the whole thing pop up. We've got this artichoke tree at my house, and my 3-year-old, like the first year it was 1 artichoke and it was like this big. The second year it was like 5 artichokes, and this year it was like 300 artichokes. And my 3-year-old is like, you want to teach about abundance? That's abundance. You can't eat that many artichokes. We're only 4 people. So where do you start from there? Well, you can give it to your neighbors if you want to, be a little bit be, a little countercultural. But ultimately, that is, you want to teach about abundance, grow some stuff. I want to share about this guy. So this guy is by the name of Dr. Rangan Chatterjee. You probably never heard of him. He's a doctor in the UK. He actually has probably the biggest podcast in the UK. But I want to show this because this was a TV show. I think we missed a massive opportunity in COVID to create content that would help people understand their role in being healthy, right? If you had that kind of content coming in when everyone's sitting at home, we had that much attention, right? We could have done that. What happened in this show? This show was called Doctor in the House. It went to 10 million people in the UK. And the premise was this doctor comes to live with you for a month with someone with a really chronic illness and basically watches you live and do the thing. So in some ways, it's the most inefficient of all possible things, right? You're paying the highest priced doctor in the UK to come and live in your house. But in the first season, with relatively simple things like type 2 diabetes and other, those kind of issues that he was dealing with, everyone got better and it sustained. And he just it was an amazing show because what it did is it grew the Overton window of possibility in medicine, right? Do you know the Overton window, the phrase? It's what are the whole realms of possibility? I don't think the average Tennessean knows that an autoimmune disease is reversible, where you can get back to being almost normal after having an autoimmune disease. I don't know that the average Tennessean knows that cluster headaches are reversible and you don't have to live in pain for the rest of your life. But it happened on the show. It happened. You can watch it. 5 million British people watch it. It was amazing. The only reason I know about it is because I'm friends with him and I found it's not even online. It's hard to find it. The BBC made it, but we could do that. It's not that hard. Right? It's not that hard. He's amazing and it's great and he's well-trained in functional medicine. He did it. But if you want, we need to grow the Overton window of the fact that chronic disease is reversible if you choose to participate. And I would love to see the Blue Zones do it. I actually took Rangan to LA right afterwards to try and get a TV deal to do basically the same as that, but neighborhood by neighborhood, which is something you guys were talking about earlier at the Blue Zones. And I had it all lined up, and then Rangan decided he didn't want to come 6 months a year to live in a caravan to shoot a TV show. No problem, he's got kids. Who would want to do that? But still, there's an opportunity for us to use public TV, public radio stations. Public radio stations were a disaster during COVID. We had so much opportunity to educate the population. All right, so if the culture isn't creating enough health that now we still have unhealthy people, which we've got a lot of work to do in the culture in Tennessee. Community is the next thing, and that's why I'm excited with the Blue Zones. This is what they focus on. And Michael actually mentioned this earlier. There's this town in Frome. They got everyone fired up about community. They tried to solve loneliness, and they did solve loneliness. Today, they have 2,000 of those people. In a town of 100,000, they have 2,000 people that voluntarily wear a green lanyard walking around the town. Can you imagine that? Is lanyard an English word? Do you guys know the word lanyard? Yeah, lanyard. Yes, like a Miss America pageant thing, right? Imagine wearing a green one of those. Now, if you see one of those greenies, what can you do? They will connect you to either a talking cafe, which is where health coaches that work for the clinic will sit, and people can get sent there. And what do they do with those people? They send them to a database of communities that already exist. I'm doing an event like this in my county on the 5th of April called Healthy El Dorado. And one of the things that we're going to do there in the first hour, it's a bit like this, but it's instead of it being like it is here, where you guys are all the partners, businesses that are creating health, it's for the general public, and the partners are recruiting the people in. And we're doing it at a high school. We got 2,400 seats. We're trying to go as big as possible. But the first thing that we're going to do in the morning, has anyone seen Slido or those things where you can have automatic engagement with the community and you can text? So we're going to do that, and we're going to co-create that database of existing communities in real time at the event. So at the end of the event, there is a list of 1,000 communities. Could be the church that runs all these different groups. Could be those kind of groups, could be men's groups, could be sauna groups, could be sports groups, whatever groups exist. Let's get a list of all of them that exist in the county. And then in this model, they had 2,000 people that were literally recruited to wear a green lanyard and connect people to that. That's not that hard. You guys could do that by next year. You could have a list of all the groups that actually exist in every county, and you could arm the primary care physicians at SOFA, at Highlands Physicians to say, hey, let me connect you to one of these databases. That's not that hard, and they did it. And look, this is what happens. In Frome, these are the emergency room admissions, and this was the rest of the county. This was the town of 100,000, this is the whole county, and this is what happens. Lonely people end up in the ER. All right, give you a couple case studies. Most of these case studies are from the UK, which I realize, I'm not sure why, but I think one of the reasons is because they have the right incentives, right? They have incentives to cut costs. They have incentives to innovate because it's a single payer system. But David Unwin, he's a single GP in the north of the UK, and he decides with his wife that they're going to start a type 2 diabetes reversal program on a Thursday night in group, him and his wife, voluntary. Like, this guy's paid as a GP. He doesn't, he's just doing it on a Thursday night. So this shows over this time, essentially half the people that join this type 2 diabetes reversal group reverse their diabetes. Half, right? 224 people reverse their type 2 diabetes. This is what the drug spend looks like in his clinic for diabetes drug compared to other clinics in the area. Any clinician knows that the drug spend on diabetes drugs is only one factor of the total cost of care, but you can be sure there's less COPD drugs and whatever, fatty liver drugs and depression drugs and all the other drugs that a person with type 2 diabetes is on. But this is just the savings there, and they reckon that if everyone did the same thing, it would save like £250 million. But that's just on the one drug category. That's not the total cost of care. Case study 2, Patrick's here, the Cleveland Clinic Center for Functional Medicine, 2019, they showed that functional medicine essentially outperformed Cleveland Clinic conventional medicine with outcomes. And then in 2021, by doing the groups, by putting these people in cohorts and doing it in a shared setting, better outcomes at significantly lower cost. And this, I want to show you. So this is when, going back to the story, I wrote the book, and then it was March 2020, and I'm sitting around saying, I've just spent the last year convincing myself that this should be the thing we should do. No one's going to do it. Let's see if it works virtually. And ultimately, we stood up something in the middle of 2020. By the end of 2020, we had our first clinic using these virtual groups, using essentially Zoom and a curriculum. And then by the middle of 2023, we had 2 health systems, 50 clinics around the country, 2 health systems and ACO doing it. I will tell you, as you could probably guess or just intuit, that a Zoom group is not as cool as an in-person group. Everyone's spent enough time on Zoom to know that Zoom has limited coolness or limited connection. But if you want to scale groups out to a whole population, workflow changes, all the internal things that have to change on the physician and clinic side to execute it, this is way better, way better. You don't have to worry about people driving to the event, they missed it, the parking, the bus, the physician workflow, all these things. So remember what we were saying at the beginning. Remember I showed you the graph of what happens to the average person who's on those drugs, those 10 drugs. Imagine if this was the front of medicine. Imagine if the majority of people had a market increase in their mental health and their physical health. You saw it in the N=1 with Dr. Mabry. Part of the reason why I came here to speak is because, it's not often that a doctor like Dr. Mabry stays in the system and tries to change the system, but he's doing it. This is it. Like, we're doing it right here. Look at the outcomes that came from that one group. How do we get it to the other groups? This could be at the front of healthcare. Coaching. All right, so if the culture's wrong, the community's not getting it done, we might need individual coaching. What is the power of coaching? We could all use a health coach. It's catching on in the New York Times. One day you will tell your story of what you overcame and went through, and it will be someone else's survival guide. This is the biggest resource that is completely free that we use to 0% of its potential. You want to transform Healthy Tennessee? The power of one person supporting another, especially the person that has gone through the transformation. Right? You want to bend the cost curve. You want to radically reduce the cost curve. You want to take the cost out of the system. All you have to do really is get the first 1,000 people to go through the system and reverse their chronic disease, and then they can take 1,000 people each over the next 20 years. There is literally nothing more life-affirming than being someone else's survival guide. It makes all of the pain, all of the suffering that you've gone through worth it, because you can help others. This is purpose. This is meaning. This is all the things that people want in life and keep them moving. All right, so now we've still got people who the culture is not working for them, they're unhealthy, the community group's not working, even the health coach hasn't got them there in doing these healthy behaviors. We now have to think about, what care are they going to get? Are we going to do the drugs from the beginning again? Let's not do that. Let's do something else. This is the foundation of functional medicine, and I just put it in this way because I just want to show you how much sense it makes. So on this side, you can see all of these things could cause depression. Depression is multifactorial, and most chronic illnesses are multifactorial. It could come from all these different areas. At the same time, if you have an underlying cause of inflammation, it could cause all these diseases. I'm not going to pretend that it's going to be easy to transform a whole workforce to functional medicine, because you have to unlearn quite a bit. But ultimately, it's about understanding the body as a complex system. It's about understanding what to do to input into a complex system. You know, I've heard it said recently, and it really resonated with me, that science, how would I want to say this? As an economist, the reason why this hasn't taken over is because of an idea called diminishing marginal returns, right? Conventional medicine, the medicine that we do today, was so good in the, let's say 20s, 30s, 40s, 50s, in that time, that it embedded it as the system. But ultimately what we see is we have a diminishing marginal return on conventional medicine. And we're in the downslope now, right? If you don't think we're in the downslope, you're wrong. The opiate epidemic. The first opiate is great, helps people on the battlefield. The first antibiotic, great, keeps people alive. We have antibiotic resistance and we have an opiate epidemic. That's why it's not bad, it's just that we're doing way too much of it. Now, in economic theory, when you start to go down on the cost curve on the other side, the second best strategy should kick in, right? That's what should happen, because then you get the gains of the second best strategy. Why doesn't that happen? Because the system has been entrenched with the first strategy. All the medical schools, all the doctors' training, everything. That is why the market is not going to reflect that. Why does the America curve look like this? I don't know, everyone's probably seen that graph where it's like America, where it's like investment and life expectancy. It goes up and it goes down like that, and every other country just goes pretty much straight up. It's because lifestyle is embedded there. We didn't put all the chips in on drugs and conventional medicine. They kept healthy behaviors as part of the journey. So this is the functional medicine operating system. As I said, I'm not a doctor. I just recognize a new language when I see it. And we do need a new language if we're going to work together. Let me just give you an idea of what's possible here. Michael spoke about Alzheimer's earlier. How long have I got? I don't have my watch up here. Am I near the end? How many? 4 minutes? Okay, we'll whip through this. This time last year, I came to Michael's first event and I flew back in from South Africa because my father had had a major cognitive decline, right? And I had flown a month earlier. He lives in South Africa, on the other side of the world. I went to go and visit him, and basically all the doctors there were like, this is death, just prepare for death. But I had spoken to my functional medicine doctor, who lives down the road from me and is my friend, and I'd said, what do you think? And she said, if a cognitive decline happens that quickly, you got to look for an infection. So look for an infection, get the work up. If there's no infection, there might be mold in the house. So I go down there. My dad is imperceptible from death, right? Lying there, only just breathing, not opening his eyes days at a time. And I go to his flat, and it's ridiculously moldy. It had been a really wet winter in South Africa, and now I'm thinking back to all these conversations that I had to him over WhatsApp over the month, to be like, or the previous months, oh, I'm too tired, I can't get out of bed. And it all clicks in, and I realize what's going on. So I say, hey, I think it might be this. And obviously everyone looks at me like I got two heads, because like, who thinks that that's even possible? Well, guess what? She was right, because my dad, I took him out of the moldy environment and I talked to him this morning. and he reads 4 books a week. And he's not all the way back, but he's somewhat back because we understood the root cause. This is the standard of care for dementia right here. These 3 drugs, monoclonal antibodies. The no treatment if you leave dementia here, and this is what happens if you do the drugs. None of them make it go back up. We want to get the function back. It doesn't go back up unless you do this care. It can go back up. And this is my Dr. Christine Burke. Is my business partner now. I just came back from that, and I was like, there's no way we can only have, 10 clinics or 100 clinics or 1,000 clinics in the whole country doing this with no capacity. We need to work it out. This is an average MoCA score improvement. If you don't know anything about MoCA scores, getting a 1 score improvement would be ridiculous. 4.4 is going from mild cognitive impairment to health. And ultimately, I guess what I want to leave to you is just to share with you all that the Institute for Functional Medicine has done a great job in making it easy for organizations like the Cleveland Clinic to take on some of these ideas. And I'm grateful for the way that they've repackaged functional medicine for large organizations. But ultimately, the reason why functional medicine has not caught on is it's reasonably hard. It's intellectually taxing to try and understand how to work with a human body that has so many positive and negative feedback loops. And ultimately what it will take to do that is a way of automatically kind of scoring to try and understand, what's going on with the patient. And one of the things that I'm working on right now is a way to make it easy for any doctor to understand what is driving, which one of these causes is driving the dementia in this person. And for my dad, it was biome and biotoxins, it was mold, and probably a little bit of metabolic inflammation because he loves sugar. But being able to understand what's driving at that cause is where we're going, and this is where we're heading next. And to be able to see it in such an easy way so you can understand, what's driving it in this patient. This is a cutting edge solution that is coming to make it easy for large health systems and organizations to adopt this, and for it to be a lot easier than it is now. This is the model. Care needs to transform. This is the most expensive. And the last thing is cost sharing. And I'll just share this. My experience with starting the first non-Christian medical cost sharing group called New Health tells me that at a certain level, you need the members of your community to feel a sense of stewardship for their healthcare dollars, right? If you have a United Health plan and you know that you've paid so much, all you want to do is charge to your plan, because ultimately you've got to find a way to get that money back because I'm paying so much anyway. And if you multiply that by a whole population, the cost goes up like this. There needs to be some sense of stewardship. And one of the reasons why I'm here is because at SOFA and at these groups with these value-based contracts, you at least have the right economic incentive to take actual responsibility and actual stewardship for the healthcare dollars. And those incentives matter. That's why these innovations came from the UK. So that's the model, the 5 C's, the community cure. This is my effort at an economically viable path to a healthy Tennessee. The thing that I'm most excited about is that you have seen congruence here today. You have seen congruence between the efforts of the blue zones, everything that we've seen. It's about finding ways to make it easy for people to be healthy, and if they get unhealthy, to bring them back to health through methods and methodologies that have been designed from the beginning for that purpose. And I'm really grateful for the opportunity to share these ideas. Thank you.